I know there are many questions, but I think in the interest of time, and hopefully we'll have some time for questions as they evolve, we will try to put these two circles together, these half circles together, and ask Bob Black to comment for us. Thank you.
Well, let me start by thanking Keith for the idea of putting this together and for organizing it and giving me the privilege to speak in this symposium that honors simultaneously George Graham, a colleague that I have known for many years, and Nevin and Carl for their many contributions as we are celebrating today. So to start, I was going to establish my credentials by showing you my personal copy of the monograph that I acquired 30 years ago prior to going to Bangladesh. And so this is well-traveled. It went to Bangladesh with me, where the first study that I started in that setting was called the Diarrhea and Growth Study, which is not surprisingly based very strongly on things I learned from this and gaps that I identified at the time. And I subsequently moved to Peru and with the Instituto that has been mentioned and continued to do the same studies. Maybe I have no new ideas. And in fact, to prove that, my Gottlieb is here. There's a new grant from the Bill and Melinda Gates Foundation that went to the NIH Foundation, and our nutrition program is part of a consortium that is doing a new study that's called the Malnutrition and Enteric Disease Study, which you could also call Malnutrition and Diarrhea Study, but it's actually more related to gut function, a lot of the mechanistic issues. So I guess that's to say that we haven't gotten all the answers for these questions that still remain to be very important. So what I'm going to talk about, and I'm not sure if I'm going to bring these two arms of the loop together or if I'm going to separate them, because I'm going to raise toward the end a whole lot of new issues that are related to nutrition infection interaction. I'm going to make a few comments about aspects that we might say are resolved, old questions that were posed, but the question mark means not entirely. Some new twists on the old questions. And some unresolved questions that were posed 40 years ago and we don't really still have the answers, and some new questions, in fact many of them, and I'm just going to illustrate some. And this is somewhat in way of summary of the two excellent presentations we've heard. So in regard to the infectious disease contributions to undernutrition, I would say that we have now quite ample evidence that infectious diseases have a causal role in undernutrition. But we still have a lot of questions about the relative contribution of infections and poor diet in specific settings. And I think Claudio alluded to this. Probably he's right that in a setting with an adequate diet, these may not have much effect, but there are still many issues in places in the world that have marginal diets. What is the relative contribution, and what is the effect of particular interventions, whether they be infection control or nutritional interventions? Now, I would say for the first part of this, we do know very clearly that there is a demonstrated risk relationship for some of the major infectious diseases, diarrhea, pneumonia, malaria, and measles, for example. And I'm going to show you one figure here that came from some analyses done by Laura Caulfield and others of us here, which actually shows the synergy. So one of the key concepts in the monograph in 1968 was the concept of synergy between undernutrition and infectious disease, showing the higher mortality that occurs when you have the combination, so when infectious disease occurs in undernourished children. And as you can see if I can get the pointer to move. There it is. This is Z-score, and as you go from right to left, these sets of children in a population are more undernourished, in this case in weight for age, and you can see how the relative risk of mortality increases for those specific causes of death. Now, this is building on work that was done by David Pelletier and others at Cornell, showing in regard to overall child mortality, this relationship holds. We've extended this now to particular causes of child mortality. But, and this is now to the second bullet, we still have questions about the undernutrition and infectious disease synergy in regard to a number of other infections. We believe there are important relationships, but they are still inadequately studied, even for TB, which is, there's been a clear recognition of a nutritional risk to TB morbidity and mortality, but it's still not well worked out. And certainly now with HIV/AIDS, there are new issues about nutritional risk factors and conditions that increase mortality, morbidity, or perhaps affect response to treatment. And I think Charles illustrated very well, we still have a lack of clarity on a lot of the mechanisms. We have much better studies. We have animal models. We have human studies that really are looking at the innate and adaptive immunity, but we still are not absolutely clear on the mechanisms by which undernutrition affects the infectious diseases and puts individuals at higher risk. So there's still much work to be done. If one looks back at the monograph, and it was interesting to do that, I'm sure for all of us in preparing for this symposium, what I would say, just reading it, was that they actually predicted pretty well how important vitamin A deficiency was. They had a lot of coverage of the literature of the time, and I think that has been borne out, again, in what Charles told us with randomized trials and the demonstrated effects of vitamin A supplementation. With vitamin D, there was some back and forth, and I would say the evidence was unclear. There was sort of an uncertain status at the time, discussion, for example, about TB, but maybe less certain. And the importance of zinc deficiency at the time really was not recognized. So Charles has covered vitamin A, which I knew he was going to do, so I'm just going to say a few words about vitamin D and zinc. So what is the new evidence? And this, again, will lead us into research of the future. First, we know that there's a high prevalence of vitamin D deficiency in pregnant women and children, probably in the total population, in low-income settings in South Asia and in Africa, perhaps surprisingly so, because these are tropical environments where you think high sun exposure should prevent much vitamin D deficiency, but this is not true. There is a lot of vitamin D deficiency. We know that low concentrations, and these are case control studies, low concentrations of 25-hydroxyvitamin D is associated with an increased risk of acute lower respiratory infections. This has been shown in India, Turkey, and by one of our doctoral students just recently in Bangladesh. And we do have some clues on mechanisms, but these are still hypotheses. For example, we know that there is a role of vitamin D in immune function. For example, there is endogenous synthesis of a peptide, an antimicrobial peptide, that particularly is associated with mucous membranes, and particularly respiratory mucous membranes, by monocytes. And that peptide synthesis is dependent on activation of the vitamin D receptor. So there are clues that we can build on that where we might be able to understand these mechanisms while we're doing further clinical trials or field trials. The evidence on vitamin D deficiency has accumulated rapidly after the initial demonstration of the human effects of vitamin D deficiency, zinc deficiency. Then additional studies have been done, particularly a great number of trials. So with the recognition of a high prevalence of zinc deficiency, there have been many trials, clinical trials, field trials, that show that collectively there is a 14% reduction in diarrhea incidence in zinc supplemented versus placebo supplemented children, and a 35% reduction in clinically diagnosed acute lower respiratory infection incidence. We have some clues again about the mechanisms, but zinc deficiency affects virtually every arm and every aspect of the immune system. So trying to pin down which ones are most important still is work remaining to be done. And another tantalizing aspect, and maybe one with a practical application as well, is that we have demonstrated, and others have, that zinc supplementation prior to around the time of immunization with oral vaccines, such as an oral cholera vaccine, enhances the immune response to that vaccine. So again, demonstrating an immune relationship, but also potentially a practical application to enhance the effects of particularly the oral vaccines, where we know that in these low-income settings, the response is often inadequate, as we've seen with polio vaccine, we're now seeing with a number of other vaccines. So perhaps this is related to nutritional deficiencies. Some new twists, I guess. I thought it was important to mention that the monograph had a very large and for me personally important section on what they called at the time weanling diarrhea, because this was one of the major focus areas for the studies we did in both Bangladesh and in Peru. And this is complementary food contamination that leads to the diarrhea. And I think we know now how critical it is to enhance breastfeeding, exclusive breastfeeding early on, and then continued breastfeeding, but also how important food hygiene is, the prevention of food contamination. Now, perhaps a new twist is that we now know also that HIV is transmitted in breast milk, and we have to look at the net risk and benefit, but it has been, to me, well demonstrated that unless you're in a setting where you can really provide optimal substitutes to breast milk, there is still a net benefit to exclusive breastfeeding, at least for the first 4 or perhaps longer months, in these low-income settings, because you still have a net benefit on mortality, even with some HIV transmission. So some unresolved questions, or perhaps not yet fully studied and appreciated questions. The monograph, I think, appropriately focused a great deal on synergies, and we talked about that. But it also mentioned antagonism. And so what is that, and how might we interpret that? Well, it basically was saying that perhaps in some cases with undernutrition, there is a lower risk of infectious disease. Is that plausible? Well, one explanation for that was given is that the microorganisms need these nutrients also. Perhaps if you're deficient, the organism is starved of the nutrient and therefore can't proliferate or can't develop virulence or whatever it is. And there may be that possibility. I think we also know now something else, and this is, I think, what Charles was alluding to, this balance that the immune system needs to prevent or reduce pathology. And there are examples, as with hepatic schistosomiasis, that the response of the immune system is a very important part of the pathology. So if you have a diminished immune response, you actually will have less hepatic damage. There's also, I believe, increasing evidence that there is a protective effect of iron deficiency for malaria. And we've shown in Zanzibar, in a randomized trial, adverse effects of iron supplementation in this malarious area in regard to an increase in the risk of hospitalization and death. So iron supplementation may be hazardous, and somewhere wrapped up in here could be these antagonisms that were mentioned, but really not studied very well. And there may well be more of these that we need to understand. Okay, Claudio mentioned this, and I don't think I'm going to dwell on it, but you know, in the 60s, and I'd like to hear reflections from Carl and Nevin on this. In the 60s, there was a great deal of literature on the tropical enteropathy, and we have good descriptions of that in native populations and in others who come into those populations, and a good description of the pathology. But to what extent is that relevant today? We may have less awareness of it. We have less description of outbreaks that appeared to occur at the time. But yet we probably have, as Claudio has said, an underlying condition of tropical enteropathy that does result in reduced nutrient absorption, acute phase response, and probably has a role in growth faltering. So there is a bit of renewed interest in this. You see, I'm hoping one of our faculty, Gene Humphrey, who's pursuing this topic very actively, will be able to pursue it with some further studies in Zimbabwe. New questions. I'm going to end in just a couple more slides. So what I'm doing now is just illustrating sort of the wider scope that we might think of in regard to nutrition and infection interactions. Some things that were not conceived of before, some that are still hypotheses, some we're really not sure, except they are active areas of study. The first one is, I think, well demonstrated. That is the role of nutritional deficiencies in microbial evolution. The best example of that is selenium deficiency selects for more virulent Coxsackie B viruses and probably influenza viruses. So we have a situation where we have a nutritional deficiency, but it has a direct effect on viral evolution. We also have now active research going on in what is referred to as the microbiome, essentially just the collective microbial community of the intestine. And we know, if you try to quantify this, that the number of bacterial cells outnumber the number of human host cells by many-fold, more than tenfold. So we have an enormous genetic pool and pool of organisms that are metabolizing inside us. And what are they doing? Well, there's animal models, and there's some growing literature that this microbiome can actually be related to obesity, perhaps to undernutrition as well. So an active area of study now with better technology, with an increasing array of ways that one can go about this, both in animal models and in human studies. There have been a number of studies related to a particular infection, Helicobacter pylori, in the stomach, and nutritional anemia and potentially growth faltering. And the others on this may be still in the hypothesis, or maybe even in some cases some evidence leaning against, but still active areas of work. Possible viral induction of type 2 diabetes. We also have some animal models that suggest viral infections are associated with obesity, and what is the relevance for humans. And we also, I think Charles was alluding to some of these issues related to pro-inflammatory effects of viral or chlamydial infections and cardiovascular disease, or perhaps anti-inflammatory effects of omega-3 fatty acids or other nutrients. So I'll come back to the vicious cycle. I think there are many parts that we do understand. We clearly understand the relationships in both directions, both arms of this. Again, I'm not sure, Keith, if I brought them together, because I put a whole lot more in the middle of additional questions that I think we can all stand to learn more about, and as others have said, probably spend the next 40 years of research trying to fully come to grips with. So I'm going to end with some wise words. The first coming from the monograph, that is, interactions between malnutrition and infection contribute greatly to the health of individuals and communities. A correct, if not modest, statement. And then finally, a quote from Bill Beisel, former faculty member, professor in the school, who did really seminal work on nutrition-infection relationships. And that is, the bidirectional relationships between host nutrition and infectious diseases are exceedingly complex. Despite many studies conducted over the years, these multifaceted associations are still incompletely understood. This was at the 35th anniversary of the publication of the monograph, and there is a journal publication on this, and I think we would still agree they are incompletely understood, but we are making progress with better tools and smarter minds than mine, having studied this for a number of years. So nice to be able to speak to you today.
Thank you very much, Bob. I think you did bring the circle together and you opened it back up at the same time. And that is to be expected, or else our young professionals of today would walk out the door and say, what do we do now? I think in the continued interest of time and to give our two major guests a chance to comment on what has been discussed, ask some questions amongst themselves, and to keep this discussion going, I would ask Dr. Schrimshaw and Dr. Taylor to come up and have a conversation with us. And we're doing really, really well in terms of time. I think we'll have some time for questions at that point to anybody who has spoken at that point. So Nevin and Carl, can we ask you to come up into our living room and have a seat and share with us some of your thoughts. I guess as you're crossing my field of vision here, Nevin, as you approach your seat, I would ask you to give us some comments about what was going on in the 50s, what converged in the 50s and 60s. I needn't say how special this is. But we'd like to know what was going on in up to the point of that monograph that drove the two of you and John Gordon to write what you wrote, to think what you thought, and to that served as a platform for us to be here today talking about what we're doing and what we need to do over the next 40 years. Small question.
Well, clearly, John Gordon was a catalyst and a mentor as well as an editor for us, and really brought together the elements of the monograph, but I'll tell you some other secrets in a moment. But it's hard to realize that when I went to Guatemala in 1949, there was absolutely no sense of relationship between nutrition and infection. I didn't know much nutrition at the time, so I looked up in the big textbook of nutrition. Well, I think in a moment, but at any rate, this thick tome with lots of pictures and so on, and I went to the index, and under infection, there was one entry. I went to that entry, and it said there is no evidence for a relationship between nutrition and infection except possibly in the case of tuberculosis, and that was it. Well, how did the research that resulted in the stimulus for the monograph come about? Well, it probably really came about in two ways. One was from the early research of INCAP, which made so clear these relationships, but that was stimulated by my participation in 1950 in the second FAO-WHO Expert Committee on Nutrition, at which John Brock, an internist representing WHO, and Otre had toured Africa because the WHO had been hearing about a disease described in different parts of Africa with different names, and they sent them to investigate this. And the Brock-Otre report to the committee, and later published, made it very clear, first, that this disease was all over Africa under many different names, but it was the same disease. And it was the same disease that had been described in 1933 by Cicely Williams and published in The Lancet and in another paper in 1938. And she had done a beautiful description of kwashiorkor, including analyzing the way in which infection precipitated the kwashiorkor as an acute disease in already severely malnourished children. Well, I knew that I had already was seeing this disease in Guatemala, both in the pediatric wards in the village, and that I'd seen it during my internship 3 years earlier in Gorgas Hospital in Panama. And so they gave me the funds to hire a Guatemalan physician, and the FAO sent Otre again. And this resulted in the small monograph, Síndrome pluricarencial de la Infancia in Central America. Now, and it confirmed everything in Cicely Williams' papers, and very soon it became the stimulus then for in-cap studies. But in the meantime, they'd sent John Waterlow to Brazil, who described the same thing, and then found, then it spread, and it was clear you could go into almost any pediatric hospital in the developing country at that time and demonstrate cases of kwashiorkor. Now, our starting point was our work with kwashiorkor. And pretty soon we had clear-cut examples where measles or chicken pox, German measles and others, as well as multiple diarrhea had precipitated kwashiorkor. We also had examples where multiple infections had changed a satisfactory, you saw what was called a monogram. I think that that's a very nice name for it. But there are dozens of these coming out of Mata's work in CAP, but our earlier work showing that infections did have this effect. Gradually, we had very strong evidence that infections were increased in the malnourished individuals compared to the well-nourished individuals, and so was the growth. And this was true for particularly, we did quite a bit of work on diarrhea, some of which was later explained by the work of the mullahs in Dhaka with the effect of the differential effects of the different enteric pathogens. Well, also mortality from infection was influenced by weight for age or nutritional status. This was becoming increasingly clear. Wasn't anywhere collected in the literature, although there were individual papers suggesting this. And so I put together some papers, and I gave a lecture at the first Asian Nutrition Conference in Hyderabad, and I gave a lecture at Harvard. And both times, very prominent nutritionists came up to me and said, if that's all the evidence you got, I don't think the relationship between nutrition and infection was very important. Well, it was about that time that I came up to Harvard and came into the second semester of the School of Public Health. That was, what, about 1968? At any rate, John Gordon had a famous class, EP15, in which he would admit only a privileged few who were preparing field projects. But when he heard about our work in Guatemala, I was admitted, and he gradually became aware of this and brought Carl in, and we'll talk, and Carl will tell you about that too. And John Gordon was the editor of a section of the Annals of Internal Medicine, a public health section. And he got the idea that we should write a review article. And when I came back in the fall, we did just that. And at that time, we had about 80 relevant references. And to our surprise, after total indifference and neglect of interest to EPA, certainly on the part of nutritionists, and also people working in infection, on the interactions, this review was really had some influence. It was one of the top 10 cited articles for quite a number of years, and interested WHO. And WHO asked us to put this into into the WHO monograph that you know and are talking about. Everything that you heard this afternoon is relevant and wonderful for us to hear, to know that the monograph did have some effect. But it was very clear that there were some things that we did not know in the monograph, and that hasn't been brought out yet today. We knew that infection was increased in malnutrition, but and we knew that antibodies were important, but the degree of malnutrition in the population we were studying wasn't sufficient to interfere with antibody response. Even in kwashiorkor, 2 days after treatment, antibody response was restored to normal. And then Bob Black and Ken Brown from Africa sort of entered the fray because the viral antigens were not, the response to the viral antigens were not affected by malnutrition. I guess there was a little response in some of the bacterial antigens. But it was clear to us that the antibody response, humoral immunity, didn't explain what we were seeing. And the monograph sort of ended at that point in saying, and we looked at intestinal flora and made speculations and so on, but the monograph ended saying we didn't know the mechanism, but we suspected it must have something to do with white cells and so on. Now this was before cellular immunity and the whole explosion of immunology. But that explains that vacuum in the monograph. Now what the monograph did do was very specifically explain how infection influenced nutritional status. And the interesting thing is that any infection, no matter how mild, has an adverse effect on nutritional status. Whether or not this is of any nutritional importance depends on the nutritional status of the host. And in a well-nourished population, this is unimportant. But the 17D strain of yellow fever vaccine, no febrile response, but definite decrease in appetite, definite increase in urinary excretion of nitrogen, catabolic response, increase in vitamin A, excretion in urine, etc. So I feel that and then, of course, the beautiful work of Bill Beisel supplemented our nitrogen balance studies in children, and then just, I think it was after the monograph that we understood the effect of interleukin-2 and the whole catabolic stimulus, cytokine control of the catabolic response. Now I'm going to stop at this point and let Carl pick it up.
Well, let me start with picking up something from what Keith said about George Graham, because it was very important part of the whole development of the idea of having a nutrition division in the Department of International Health, that we were fortunate that during the time that we were really getting organized as a Department of International Health here, that we had the well, it was during the period that John Hume was dean, and he and I were talking at that point about nutrition and infections. He'd been in India, he'd seen our work in India, and so we started immediately with the ways in which the Department of International Health really needed something that covered more than just the infection control that we had started with. And then we got into negotiations in the mid-1950s about the possibility, and here I really give John Hume the credit for persuading the medical school to let us transfer George Graham to the school here, with one very fascinating thing that came out in the discussions was that the monograph had just come out. And so we were able to use the monograph as part of saying that the Department of International Health should have strength both in nutrition as well as in infection control, because it'll give a chance to bring the two together. And one of the great things about having Bob Black in the role that he has had is that he has done that. And so I just want to start by recognizing how this all evolved in association what has developed in the school. My own personal involvement in this issue came when I too was at Harvard being interviewed for possibly getting into Epi 15. And let me just comment incidentally that one of the interesting things that came out in the conversation that Nevin and I had over the telephone a few weeks ago, and even though we had worked intensively together in the whole process of developing the monograph, he and I had never shared the very important fact that we had both gone to Gorgas Hospital in Panama for our residencies and internships. We had been trained there, and that we had had the opportunity then to get the same sort of backgrounds that we...
The tuberculosis and malaria were the leading causes of death. Out of our 16 interns, 3 came down with tuberculosis and 1 died from complications of it.
And it was something that being there was part of, well, it was also a very positive experience. And it was a chance in which we really began to understand the way things worked and didn't work in developing countries.
It was a wonderful training.
But I think that the main point that I wanted to make about going to Panama and being part of that background was that it gave me a chance at that point to begin to really see the relationships between things that were not being done. And so I then went to work in India, as Keith mentioned, and then after a period of work there in the mission hospital and then at the Christian Medical College, I had a chance then to come back to Harvard and come be in the groups that were being interviewed by John Gordon. And one of the first things he asked any student coming in for trying to get into this very special course was to tell him what we thought was the most interesting question that remained to be answered by somebody going into public health. Unfortunately, I had something that I'd really become concerned about as a result of my work in the villages in the Punjab. And so I immediately said to him, well, the thing that impressed me about working with village children in a place like the Punjab is that all the work you did, you could show that every child was loaded with infections. But then when you looked, as you never did, into the literature, you found that nobody really paid any attention to the fact that these children had both malnutrition and infections, and nobody was looking at the relationship between them. And so that question was what I posed to John Gordon as the thing that I would like to focus on if I got into the year's course. Actually, it was a course that went through the full curriculum. And it was very rewarding to have John Gordon, who was really one of the leading epidemiologists in the country at the time, to immediately pick up that idea. He had said that he had spent many years worrying about why nobody was interested in the interactions, not just between nutrition and infections, but also between all diseases that people were getting. And nobody really paid the attention to the interactions between the illnesses that people had, and of course, particularly with children. And so we got immediately into a fascinating discussion. Now, one of the things about John, who was a crusty old Scot type, was that he had a sort of a personal idiosyncrasy that if he got an idea that he thought was interesting, he immediately put his own label on that. And so when I said that this was the idea that I was interested in, he said, great, he was interested in it, and he had a label for it, and that was the word concatenation. Now, do you all know what concatenation means? I thought it was something that meant you were sort of confused when there are too many things going on. And so I said that, and he said no, and then he gave me the dictionary definition, which was very clear. It means that it's a process that you go through in order to link in a chain the way in which one activity influences another. And so he was right on in terms of what we were concerned about. And then we started to work on the whole idea of the way in which synergism and antagonism developed. And he finally, after a year, agreed that, okay, we can drop concatenation and just talk about synergism and antagonism. And so from that point on, we really set this up as a major activity of the department, of the epidemiology department at that time, building on the issues. That was in 1953, I believe, that we had that exchange and started that program. Then it was 1958, I think. When was you came into the department?
It would have been about 58, yes.
58. And so, just to follow up the kind of pattern that Nevin talked about with his own experience, we, working in the Punjab in India during those years, were able to start some very active programs also, mainly in field work. That was the kind of thing that we've done, called now trials, but that was a very preliminary effort. We had a person named John Wyan that did some early surveys in the villages of the Punjab, and was the first reports then published showing that the 4 main causes of death in the village for all ages, the 4 main causes of death were all in children, and they were diarrhea, pneumonia, tetanus neonatorum, and then chronic malnutrition. And so we were then into the work in which the Kunda study and then our Naringwal studies became very focused on following up that kind of thinking. First going into the very obvious activities that needed to be done in the Indian villages in terms of diarrhea and pneumonia and tetanus neonatorum. And then when, as I said, John Hume brought in the department, into the department, the nutrition division, it totally changed the whole picture of how we were able to continue those studies. And I'd just like to say one other little thing that I found very interesting in that negotiation that went on at that time, which was very complicated actually. Working in India is not easy, as you probably know, but we were very fortunate to develop a very close friendship with Dr. Sushila Nair, who had been Minister of Health for a long period of time during this and during the period we were working there. But because she had been Gandhiji's personal physician, she had very high status. And she actually had come to Hopkins and did her doctorate in MCH at that time. And so we had immediate linkage to support from the Ministry of Health. From that point on, we were directly under the Indian Mountain Council of Medical Research. We were given special relationships in terms of getting what was, I suppose, one of the most useful things that we had from the U.S. in India at the time, which was the PL 480 grant, which was all the dollars that had been converted into rupees and were owned by the U.S. government. And the government didn't know what to do with it, all these rupees, and so we were able to get very liberal grants to do massive studies in the kind of things that were becoming of more interest to the Indian government. And as a result of that, as we began to develop in these field works, we set up the base in the villages. All of the people working on the project had to live in village homes that were converted. And we developed a whole system at that point of getting participation of the village people in a community-based type of relationships that became very popular with the people in the Ministry of Health. And I guess the way in which that evolved was that brought in Indian institutions that we were able to cooperate with in doing some of the lab studies that we were also involved in. Just one further aspect of that process as it then related to the maintaining the relationship with John Gordon and what was going on now in relationship to the monograph was that it became very, very important, I think, to have both the opportunity to work with Nevin and the whole Central American and then the international base of relationships that he had through INCAP with WHO and all of the people that were involved at that level. And that teamwork or partnership that developed, as far as I was concerned, was really so important in terms of the way in which we learned to work together. I can remember that we argued a lot, but we never, that I can remember, after the end of that argument, we never failed to get a good, solid agreement.
Well, that's true. And let me give a little bit of anecdotal information about John Gordon, because when that first semester that I went to the Harvard School of Public Health was his last, and he was forced to retire. And I came back, and he was in a little office in Spar's drugstore. He soon developed ulcers, I think, fore and after the hip pylorus, and was ill and unhappy. And at the same time, about that same time, I was appointed a department head at MIT, and one of the first things I did was find an office and bring John over to the department. And every summer, for the first about nearly 10 years, I went down and taught and did research in Guatemala, and John Gordon and his wife Marion would come along, and we would work on the monograph. But going back for a moment to that, the earlier article in Annals, Gordon was the editor of this section, so he was very, very demanding, and went over and over and over that thing. I I think, 1,000 times, and finally, I considered it the shortest or the most condensed telegram I'd ever written. But the fact that he could come down. Another very key factor was that Carl had a very good secretary who was able to look things up in the Countway Library, and he went off back to India and left her to work. So if she hadn't been spending week after week after week in the Countway Library, the monograph would never have been done either. The other point I wanted to make is scientific and is important. One of the field studies that we did, the so-called 4-village study, came about because nutrition did not appear significantly as a cause of death in the official statistics of Guatemala, and therefore it didn't appear in the official statistics of WHO. And yet we were seeing deaths that were clearly nutrition related. And so what we did was in 4 villages have village workers, and ethically we couldn't have a physician in there because they'd have to treat anybody who got sick. But these village workers could come out of the village and report to a physician, and if he needed more information about a death, they could get it. And they were, instruction was to follow every sick child, and if a child died, try to actually see the body and be able to describe it and bring this information out. Well, this study went on for 2 full years. And the official vital statistics, that is what the person who recorded it in the village sent into Guatemala City, had 40% of the deaths from lumbrices, from worms. And presumably, the people saw the asterisk on the stool, and that they attributed the death to that. And then the others, there were a miscellany. When we looked to what we thought the real causes of death were, we found that all of that 40% of lumbrices were children with edema, skin pigmentation, pale hair, apathy, the classical signs of kwashiorkor. And then the remainder were divided between diarrheal and respiratory disease. But the kwashiorkor would not have occurred had it not been for series of diarrheal infections or other precipitating infections. So here was a synergism of nutrition and infection. The respiratory and diarrheal disease would not have been fatal in well-nourished individuals. So here again was a synergism between nutrition and infection. And we carried this information up to Pan American Health Organization in Washington, and they were very skeptical. But they did have a statistician, Ruth Puffer, and an epidemiologist, Serrano, and they sent them to 12 general hospitals in Latin America to look at the records for the cause of death. And of course, this would be incomplete. But they found that in nearly 60% of the cases, whether usually it was reported as a death from infection, but malnutrition was mentioned. So I'm still sure that the data getting into Geneva and being reported fail to recognize the extent to which nutrition is a component of the deaths.
Doctors Schrimshaw and Taylor.
Tell some stories.
This is... We are just getting into the meat of it. We can still tell stories. We have a lovely reception upstairs with a microphone and a speaker system. Only we also have wine and some music and great food to continue this over. So I would say if there's one more thing you want to say, just say it now and just stimulate us so that we can't wait to get upstairs and talk more about all of this.
Well, there are so many things on this point. One more. I guess
Well, two.
I'd like to go back to John Gordon. One of the things that I'm most pleased about, Keith, is that you said that you are going to take the first chapter from our monograph and include it in the new volume. That makes me feel very good, because that first chapter is really the John Gordon philosophy of epidemiology. It is the basis for how you think about taking a totally sort of undiscovered type of thinking or undiscovered scientific process and then begin to try to think through what are the really important things that you can do about that. And John Gordon was truly a believer in the basic public health role, not just of the health services, but of the people that you're dealing with. And in his way of thinking through the way in which a system can be made active. And I'd just like to talk about the fact that the 4 diseases that I mentioned that was found in the first surveys that were done in the Punjab, and in India, nutrition was really so clearly synergism that that's where the weaning diarrhea just became a very obvious type of
And that was
direct.
Gordon's concept. Weaning diarrhea was his specific contribution.
It was his word, his label on and it was very clear that this was something that we had as a very firm base already, just from the limited science that was available, that it was very clear. Pneumonia was more interesting. And here it turned out to be a very complicated sort of a situation in the Punjab. And I'd just like to mention that we were at that point struggling with what can you really do about pneumonia, and all we could do was identify a case in a baby and then try to give them penicillin in those days. And it was not something that was going to be easy to do the way diarrhea was easy to recognize. And so we were trying to train the village health workers to how to diagnose pneumonia. And after a day of that training, the women in the group said, "This is nonsense. You're trying to teach us to use a stethoscope. Don't. That's a waste of our time. We don't want to learn." They rejected that. And then, this was after observing what we were trying to do. They said, "We know which cases have pneumonia. We don't need your x-rays. We can tell. We've been sitting here watching the x-rays and then looking at the babies while you were doing your teaching, and we can tell which babies have pneumonia." Unfortunately, we didn't laugh at them. We said, "How?" And they said, any mother who has carried the baby on her hip will be able to tell you when a baby is breathing fast or when a baby is having trouble breathing. And just look at the babies, and you've got the answer to this problem of diagnosing pneumonia. And that was the beginning that was the first report, published report then, of the official WHO UNICEF method of diagnosing pneumonia, which was something that was discovered by the village worker, and then they told the doctors. And so we did a trial, and we compared the professor of pediatrics in the medical college with the women in the group. They came out with the equivalent results, which was one of the most interesting little studies that we've done. So we had a very clear now example of something that really worked. And just one other part of that is what happened with tetanus, because here there was no easy way of linking it to malnutrition. But when we reported that this was the third cause of death overall in the villages, the people in the Ministry of Health, just like your people who in Washington, they ridiculed it. They said, that's nonsense. You say that that's the third cause of death in our villages? It couldn't be true. We almost never see it in the hospitals. And they said, obviously, if it never comes to the hospital, the data are false. And so we had to go back and collect data for a whole year. Then went to them and said, now we can tell you why you never see it in the hospital. Because the people in the villages said, there's no point in taking them to the hospitals. They die anyhow. And they said also that the doctors are so dumb that they don't know that spirits cause death. And so with that kind of a response, we were then able to set up the whole system so that in 1 year's time in the Naringwal project, we were able to totally eliminate the third cause of death. And that is another example of how the flexibility that John Gordon brought into the epidemiological approach to try to understand activities that are really happening in the village, that you can talk with the people and begin to get the guidance that will begin to help the scientific work that we were able then to bring in together. And so I guess that the real challenge that I see now is to take that first chapter and to begin to think about what do you do after you've already done the mechanistic type of research to find out just what are the causal relationships in producing these. But now what do you do about implementing programs that are going to make a difference in the way that the children's health is preserved? And it's that challenge that John Gordon was particularly promoting. And that is my feeling now that this is now a major challenge for this field. That we know that one of the biggest problems with the health system is the fragmentation. And one of the problems we dealt with was fragmentation between malnutrition and infections. An obvious thing now, but something that presents a model of how we can begin to do something about the fragmentation, which is so powerful as the reason that the health system of the U.S. is not doing what it's supposed to do. And it seems to me that we have an opportunity to use the synergism and antagonism concepts of how you can integrate and bring together the things that we learn in a way that will really begin to make a difference. And then it's only as we begin to have that kind of broader perspective coming out of the very great need for beginning to combine the technical, mechanistic type work with the community-based public health type of activities that, to my mind, represent a tremendous challenge at the present time for the whole U.S. health system and for health systems around the world.
Well, thank you very much. I don't think any of us can think of a more important set of lessons or discussions to hear as young researchers or older researchers in public health than what we've just heard. I want to thank very much our speakers, Dr. Stevenson, Dr. Lanata, Dr. Black, Dr. Schrimshaw, and Dr. Taylor for a magnificent start of this endowed lectureship in the name of George Graham. The Mittendorf Foundation has given us a financial base to have this lecture now every year in our academic calendar, and our 5 speakers have given us an intellectual pillar on which to build future lectures that will stand the test of time in terms of being one of the great ones. Thank you very, very much.
Can you spare one of these?
And everyone is invited to the 9th floor for an absolutely wonderful reception. Please head up there as quickly as you can, and we'll join you up there.
I don't have an English version.
I have the Spanish and the French and the